Good afternoon and welcome to our Oak Bend Medical Center Happy Hour podcast. My name is Donna and I am your host. I'm very excited today to introduce our guest as we speak about diabetes and foot infections. Dr. Alpesh Patel is a podiatrist born and raised in Nairobi, Kenya, and has inspired to join the medical field by his mother's compassion for nursing. Dr. Patel enjoys seeing patients for many foot issues, but he is passionate about wound care and limb salvaging. He resides in Sugar Land with his wife and two daughters. Welcome, Dr. Patel. We're glad to have you today.
Nice to be here.
So, we've been doing a lot of issues with diabetes because it seems like the root of all evil sometimes. And feet are extremely important. So, we'd like to ask you some questions about diabetic foot infections. And when do you go to the doctor?
Right. So we have a lot of patients that wait and wait and wait until it's too late and end up in the emergency room. So any diabetic, any patient who is a diabetic needs to have foot exam performed, with their primary care physician on, every 6 weeks or 6 months or whenever they have their opportunity. The most important thing I tell patients is, hey, when you go to their office, your internal medicine's office, just take your shoes and socks off. And when they walk in, they'll be like, hey, why are your shoes and socks off? So they can, you can guide them and have them perform a foot exam. Especially if you're diabetic or if you have had a history of poor circulation, if you have coronary artery disease, because if it starts in the heart, the legs are probably, the next in line for poor circulation.
So, who would be at risk for developing a foot infection?
Anybody who is a diabetic who has poor circulation, history of smoking, are at a risk of developing. I mean, we have young patients, 20-year-old patients, 25-year-old. We have a 99-year-old gentleman right now who's got wounds in his feet right now that has infections. It has nothing to do with age, it has to do with circulation, lifestyle, how well they take care of their feet, factors such as those.
So, I also have a question because you always hear diabetics need to see a podiatrist at least once a year to
Right.
have their feet checked and their toenails and all that.
Right.
Why is it unsafe for a diabetic to trim their own toenails?
So many reasons, because they may have poor circulation. They mainly develop poor circulation because the arterial flow, the flow to the feet are impaired. They may be at a risk of, the skin is atrophied or thin. So the chances of getting an ulceration or infection are higher, because if you think about it, it's like gardening your plant. You could have the best plants in the world, the best location, the best dirt from Hawaii. And if you don't water them, they all die. So when they have poor circulation, the nutrition doesn't get to the feet. The white blood cells to fight the infection doesn't get down to the feet to help them. And then when you take the antibiotics, it's carried down the bloodstream to the point where they have infections. So the whole idea is to prevent them from getting an infection. When patients go for pedicures, because of the COVID era, we started doing this thing called waterless pedicures in the office. And it's just a moisturizing cream in a sock form that we apply there so they don't have to soak their feet. The nails become soft and then you can trim them. In general, patients who are diabetic have poor circulation, end-stage renal disease, have issues with vision. They all need to see a podiatrist every 3 months, especially if they have bony prominences, if they have corns, calluses that need to be treated by a professional.
Now, women love to go get their pedicures.
I know, I know. I have three of them in my family. And they're trying to take me with them.
Oh, you should go.
Knowing what I
How,
know, I'm always skeptical.
but having a diabetic go and get pedicures,
Mhm.
that doesn't take the place of a podiatrist, or is it safe even?
Yeah, well, it just depends where you go. So I usually tell patients that if you're going to go for a pedicure, which a lot of them do, The best time to go is first thing in the morning when everything's clean, the trays are clean, the instruments are clean. I always tell patients, hey, buy your own instruments. Whatever they need, just take your own instruments. That way, you know they're sterilized. They haven't been used on anybody else. You don't have to worry about getting an infection or transmission of infection from somebody else. Take your own files so it's not shared with somebody that was sitting in that chair before you. If and a lot of times patients they come in and they have an ingrown toenail after they've had a pedicure, usually within the first 5 to 7 days. And I'm sure they always offer you to remove ingrown toenails on the side and scrape all those little margins around the nail folds, and they get infected. So I always tell patients don't allow them to, go in there and dig out your ingrown toenail, remove them because they can cause an infection. Also, corns and calluses, I always tell patients don't let them shave them down for you. Because we've had patients come in with a really bad infection where they used a file and the file, a little piece of the metal got stuck inside the skin, and that resulted in an infection.
Mm, that sounds like good advice for both diabetics and non-diabetics.
Non-diabetics, correct.
So, how can I prevent a foot ulcer?
So examination, right? So I know we're busy, we're on the run, but the most important thing is to examine your feet daily. You want to check in between your toes, bottom of your foot. Some of us can bend down, we're not very flexible. You can use a mirror placed against the wall so you can put your foot up there and examine it. Also, they have these selfie stick things with a mirror attached to it that you can actually purchase and examine your feet as well. You can wear white cotton socks. So if you have any kind of ulceration or bleeding or infection or pus or purulence, you can catch it earlier in the white socks as opposed to, wearing black socks or darker socks.
Okay, so we hear about diabetic neuropathy,
Mhm.
and that affects the feet. What do we need to know about that? Does that make it even all the more serious to be able to watch your feet?
Yes, it is. So diabetic neuropathy is like a spectrum. So a lot of things can go wrong. For example, you may be sitting there, on a hammock, looking at reading a book or whatever, and then you feel like ice pick, somebody's stabbed you with an ice pick. And you look down and there's no bleeding, it's just the nerves acting up. So you can have a whole spectrum from complete numbness, it's a double-edged sword, let's put it that way, or you can have this burning sensation where you can't sleep at night. And then patients are placed on things called Neurontin or Lyrica for the pain that they have, so they can at least rest at night. Problem with neuropathy is because when you have no sensation on the bottom of your foot, what happens is, here in Texas, everybody likes walking barefoot. I'm from Southern California where that didn't happen much. But what happens is they step on something and they won't feel it. We've had a patient walk in with a bottle cap stuck to the bottom of his foot. And when we took the shoe and socks off, he goes, "Oh, that can't be mine." I'm like, "What do you mean?" "Oh, because I don't drink that kind of beer." I'm like, "Okay, that's a little bit different." We've had patients with wounds. You can actually stick a Q-tip from the bottom of the foot to the top, and they can't feel anything. So what happens is this infection sets in, it gets worse, they have poor circulation, and it progressively gets worse. And then they end up with a hospitalization or amputation or incision and drainage, of that, depending on where it is. So studies have shown if you have a puncture wound on your forefoot and the toes, you have a 30% chance of getting a below the knee amputation. If it's in your arch area, you have a 60% chance of losing your foot. And if it's on your heel, you have a 90% chance of getting an amputation, depending on other factors as well. The other
Right.
problem with neuropathy is, and which I call it a devastating situation, is patients with neuropathy, the fibers that allow the bones to stop when they need to stop, they don't function as well. So the joints start banging up against each other and form like micro trauma, like little minute fractures, especially in the foot with diabetics with neuropathy. When that happens, the bones start becoming, bones demand increases for oxygen, for blood flow in that area. When you have a lot of blood flow in the area, the bones that are nice and brittle and solid become like butter and very soft. And then the arches collapse. So you can have it in the ankle joint, you can have it on the first metatarsal, you can have it on the side of the foot, and then the joints start becoming dislocated. And it's one of those things, it's called a Charcot foot. And it's a thing that a lot of physicians, primary care physicians, even podiatrists and orthopedic surgeons miss that because it doesn't present as, when you x-ray, the foot looks normal. It's just warm because you may have sprained it or been walking in the wrong way, or you may have put it in a tight shoe that can trigger off the Charcot deformity. And then a couple of weeks later, when you x-ray, you can actually see the bones are settling down when you compare it with the original. So that is something that needs to be addressed right away. Because if you don't have a fracture, you've sprained it, you don't have a fracture, they just put you in a boot and send you home, or they just tell you, put you in crutches and send you home. But as you get better, you'll start walking on it, and then the bones become softer and softer, and it causes deformity where you develop an ulcer on the plantar aspect of the foot or on the side of the foot, because you can't get that foot back. So we immediately, at the wound care center here, we actually put them in total contact cast. So it's like a casting system to control and prevent the damage from getting worse.
So, do diabetics need to wear a certain kind of shoe, or is there one shoe that's better than the other, or people with circulation issues?
Yeah, so shoes are a big thing, right? Because they can cause ulcers and blisters, that we see that all the time. So the most important thing, if you're a diabetic, every year, Medicare, I know for a fact, and some private and commercial insurances will offer you a diabetic shoe once a year with custom inserts. You get 3 pairs of inserts that go in there. They're called plastizote material, which are softer, prevent any shearing forces or callus formation on the bottom. So you get them. And they have them in different styles. Just because you're diabetic doesn't mean you can't go golf. Just because you're diabetic doesn't mean you can't run. Just because you're diabetic doesn't mean you can't be, you can't go out golfing. So they have shoes, different styles of shoes that you can get and select, and you get a pair a year. The other thing is, if you don't want to get those, or if you go out shopping for a shoe, you want to buy shoes at the end of your workday, because feet swell like 10 to 15% from the time you wake up to the time you go to bed. And so if you go on Sunday morning, you paper and go buy a pair of shoes, they may not fit you well, especially dressy shoes. If you're going to a wedding over the weekend, you don't want to go on Saturday morning and buy a nice pair of shoes and wear them if you have neuropathy, poor circulation, because you'll form blisters, they won't fit you well. You won't be able to break in the shoes, the shoes will break you in. And then wear them an hour a day, take them off, examine your feet, make sure you're not developing any blisters, and make sure they're fitting you well. Then the next day, wear them for 2 hours. So it's like a break-in period for your shoes before you have that big grand event. So when you come back the next day, you're fine. And also you want to buy socks that are cotton, so they're more breathable, and we prefer white ones so that if you have any bleeding or infection or purulence of pus, we can easily, you can easily see it. You may not feel it having neuropathy, but you can at least see it.
Okay. I know that we see a lot of diabetics that don't have good control of their sugars end up having amputations.
Right,
And some of it is because they don't get early care.
right.
What are your suggestions? What are your guidelines of when do we come see a podiatrist? And it sounds like you probably ought to have a relationship with the podiatrist in a regular visit so that you kind of walk through the disease together.
Right, right. And a lot of them, you develop relationships with the patients. So the first and most important thing is do an exam every day, right? Self-exam, just like brushing your teeth, examine your feet. So if you have something going on, you go to your primary care, they can put you on oral antibiotics and take your shoes and socks off if you don't have any problems when you're going there. So if you have corns, calluses, bony prominences, you have hematoma deformities that you're worried about, then you show it to your primary care, and they'll guide you to go see a podiatrist. And then once you see a podiatrist, so we usually see routine patients every couple of months, usually every 3 months. But if you have a problem, like they bump their toe, it's traumatic, they have an injury or what have you, then they have to come immediately to the office. If you're developing a wound, and you're not responding to IV antibiotics or oral antibiotics, then you need to come in to a wound care center like the one we have at Oak Bend, where we have a bunch of specialists working together. You have a good hospitalist group of internal medicine, infectious disease, radiologist, vascular doctor, and of course a podiatrist on board to help deal with this, devastating, you know, potentially devastating wound that you may have. And then if it's really bad, you're running a fever, you have a lot of purulence coming out of the wound bed. If you've had a chronic ulceration, no history of poor circulation, then you need to go to the hospital in the ER.
Okay. Dr. Alpash, you do a lot. I have found there's a lot of different services that podiatrists do, and you kind of do a little bit more than some. Would you explain the services that you offer to this community?
And so I do, I'm a little bit unique. I do a little bit of everything. I'm known to do some house calls where patients can come out, they're wheelchair bound or, bedridden, that need care. So I've done that. That stems from my childhood training with my mother, going to different villages for vaccination. So to me, it feels like working on a Saturday. I just love doing it. I just wish I had more time for it. So I do house calls. I work at assisted living facilities. I provide services at some of the nursing home facilities as well. In my office, we do everything from ingrown toenails, taking care of mycotic toenails, fungal toenails, to wound care, obviously, and of course, biomechanics, plantar fasciitis, and things like that. Now we're working the whole spectrum because it keeps it interesting.
Right. And you also do extensive foot surgeries.
Yeah, so my niche, unfortunately, has become, wound care. So we do a lot of it at the hospital. We do a lot of limb salvage where we try to save as much as we can on a patient. If it's just the toe that needs to be amputated, we amputate the toe, the metatarsal. We do skin grafting. We do hyperbaric oxygenation. So we have a team. We do advanced skin grafts or skin substitutes. The days of taking you to the operating room and removing some skin from your thigh and putting it on the foot are gone. We use products that are really, really, biologically compatible with the human skin, and it saves you a lot of pain and a lot of trips to the operating room. So we do a lot of extensive surgeries to try and prevent, patients from getting an amputation, a higher amputation.
And I imagine your rates of success are a lot better the sooner the patient gets into your office.
Oh, absolutely. Yeah. The sooner they come in, the quicker, studies have shown anywhere range from 60 to 80% of amputations are actually avoidable. That's a big number. Every year, 150,000 amputations are performed in the United States. Out of that, that's 400 amputations a day, including trauma, motor vehicle accident. And I'm
Right.
talking about just upper extremity. The lower extremity are 82% of all the amputations, which are related to diabetes and peripheral vascular disease. And a patient who has diabetes has 30 times greater chance of an amputation than a non-diabetic. That's pretty scary. And then once a patient has had a leg amputation, they have a 55% chance of losing their other leg between 2 and 3 years. And unfortunately, half of them will never make it past 5 years after both the legs are amputated. We've heard stories all the time. Oh, you went in for a little blister on the toe, and before you know it, they've amputated several times. So the team that we have, we always do the right thing for the patient. If there's something that we can't do, we always try it. And sometimes you just can't win based on the patient's comorbidities, how the circulation is. We can't open up blood flow, be good candidates for bypass. Then, There's prosthetics they can use and walk and get around with. And so it's devastating, but at least, you get some quality of life back.
I hope our viewers at least get, if you have diabetes, get into a podiatrist, at least get a baseline and let them examine and follow you.
So the American Diabetic Association came up with like a protocol. So if you're 50 years and older and a diabetic, they should get non-invasive arterial lines. It doesn't have to be done in a vascular doctor's office, but it can be done, at an Oak Bend, it can be done at any of the hospitals. So you have a baseline. So going forward, it's just like a mammogram, right? It's just like having colonoscopy kind of thing. So when you have a baseline, we know where you are and whether you're getting worse. And that way, we can capture it. We can have you exercise, change in diet, medications to improve the blood flow so you prevent patients from going through this devastating, situation or condition.
That is all really great information, and I encourage everyone to take this very seriously because no one wants to lose their limbs. And you get to a certain point and it's just too late. So let's try to change those statistics. Dr. Patel, I'm assuming this is covered under insurance.
What is the treatment?
The services to come see you and
Yeah, most of them are covered. The only thing that are not covered sometimes are like the diabetic shoes and some of the procedures that we do, like some of the commercial insurances do not cover. They have a protocol for applying a skin substitute over the foot or wound. Some of those advanced wound care products or substitutes that we use are not covered sometimes by the insurance. But they have a protocol which is in place, which is great because you have to have a good diabetic sugar control. Your A1C has to be very good. You have to be revascularized if it's an ischemic ulcer. The wound has to, with conservative, normal, traditional wound care, if it doesn't shrink by 40% in a month, then they may approve you for a skin substitute, which is really great because you can come in. You don't need to be taken to the operating room. You just come in, we clean the wound, apply it there, bedside or in the examination room and cover it up. And so it's just saves a lot of time and the wounds heal a lot faster with them.
And I'm sure you and your exceptional staff will help guide the patients through all of that and do what's best for them.
Absolutely.
Dr. Patel, I want to thank you for joining us today. And a big thank you to our listeners for tuning in. Beginning now, set an intention and a relentless focus on living your life as the greatest person you can be in all situations. Please take time and take care of your feet. Dr. Alpesh Patel has available appointments and will be printing that information and how to get in touch with him if you need to find a podiatrist. Please join us next week.
Thank you for joining us today on Oak Bend Medical Center Happy Hour podcast. We hope you enjoyed today's broadcast and invite you to email us at oakbendhappyhourpodcast@obmc.org with any questions or topics that you would like for us to cover. Remember, you can find us here each Friday at 5. Until next week, be mindful and stay healthy.